You get there, you see this guy, he tells you that he was outside working on the car. He was screaming outside for quite a while for someone to come help him. Took you guys 7 minutes to get there, so now let's say he's been underneath the car for 25 minutes. I know that you want to get him out right away. But before you do, you've got to make a plan. You've got to make sure that you want to have your rescue team or your extrication team ready to go. You want to make sure they're going to go ahead and communicate with your paramedics. Paramedics will have IVs established right away, oxygen on the patient. Might even want to call one of the hospitals and have them send out a trauma team with the proper medications, like sodium bicarb, calcium gluconate, dextrose, insulin, some of those medications. Have flight there if you're going to do prolonged extrication, depending on where you are in your district, are some of the things they have in place. So the communication is going to be vital. The rescue team is about ready to raise the airbags to go ahead and slide the patient out. As that's happening, the medics want to be pushing the sodium bicarb. So as those toxins start to enter the systemic system, they are neutralized basically by the sodium bicarb all at the same time. Having a doctor there or Flight for Life to have blood running so that they don't become so hypovolemic and we flood them with fluids. So we're able to go ahead and carry oxygen and still go ahead and be able to clot at that point in time. All those components should be in place. Because to be very honest with you, patients that are prolonged crush more than likely do not make it. Very few make it. And so that leads you down another avenue. The likelihood of these patients surviving without this, do we let the patient go ahead and call the family, call their family to say goodbye? Do we bring family members there on scene to go ahead and say one final last goodbye before you go ahead and lift this off and the patient goes ahead and crashes in front of you? Some of the things to think about at that point in time. I don't know what he has with mass trousers.
His mass trousers stop it from flooding the system.
Yeah, I don't know. He's got this thing with mass trousers for some reason. He keeps telling me, they're coming back, and I'm like, no, man, they're not. So, risk factors that are going to lead to renal failure. Insufficient early IV fluids, meaning you do not have IV fluids going on these patients early enough. You want to make sure that you're getting these IVs going. If they have 2 or more crushed limbs, like I said, both legs are crushed, scars on the pelvis area, delay in presentation to the hospital. The longer, this patient, once he's out, is delayed getting to the hospital, the longer or the more likely he's going to end up in renal failure. Now, most of these patients, if they do survive, are going to need some type of dialysis. Children actually are less likely to. So, but they're going to need prolonged extrication. My son ended up having a fasciotomy. I was Mother of the Year. He got kicked mid-shin, and on a Saturday night, he was like, "Mom, my foot really hurts." And of course, I thought he was just whining. So I looked at his foot, and yeah, it looked like he had a white tube stuck on, but I felt a pulse. I'm like, "Oh, you still got, a pulse going on." And the ER is not going to do anything, because all we have is a boo-boo hospital up by us. So my husband took him to the doctor the next day on Monday. They sent him from Burlington up to St. Luke's, and they ended up having to do a fasciotomy. They thought he was actually going to have to amputate because there was so much damage there from compartment syndrome at that point in time. So, yeah, Mother of the Year. But he was in therapy for 6 to 8 months. 8 months, I think it was, a little closer, somewhere right around there. Quite a hellacious scars for the most part from it.
What'd you kick him for?
Well, listen. So, disaster management. In situations where we have large building collapse, explosions, and we have a lot of people trapped, it's going to be hard to get the IV supplies. Yes, we'll do what we can to bring in as much supplies, but IV fluids and bicarb are probably going to be the biggest things that are going to need to be brought in situations like that. Anybody have any questions on crush injuries or crush syndrome? Okay, burns, injuries and burn management. many different types of burns. We see a lot of times thermal burns. There's electrical, chemical, obviously radiation, inhalation obviously are another one. But a lot of you guys are, I'm going to kind of go here for a minute. A lot of us go back to the old adage, first degree, second degree, and third degree burns. They've, again, changed terminology on you. Our first degree burns are now called superficial burns. Example, sunburn. This is just where the epidermis is being damaged at this point in time. Just the top layer of the skin. We see that nice little redness. We see a lot of times with sunburns. Maybe even we touch the stove, okay, a little bit. Partial thickness is where you have the epidermis and the dermis affected. Here we're going to see maybe some blisters start to develop. But it goes down a couple layers of the skin. Our third degree burns, or full thickness burns, are usually seen by charred skin, waxy skin. Usually not a whole lot of pain with these patients because they've destroyed nerve endings at this point. Some of you guys might remember terminology of hearing fourth degree burns, which again can fall underneath the full thickness. And that's when we start to see bone being burned in with it. So with our first degree or superficial burn, it's the epidermal layer that's affected, just this top layer. No blisters, it's just red. And the example is a sunburn. Our deep or second degree, partial thickness burns is our dermis and epidermis. And here we're going to start to see a little bit of blisters. Maybe some white skin too associated with that. Now, we get concerned when a patient has greater than 20% total body surface area burn in our system. That's part of our trauma criteria. And, you know, hospitalization, I guess, is really after over 25%. So here's some pictures of some second degree burns. Yes, leave the blisters alone. Don't go popping them, okay? Here, there's just some red, but a little bit of white skin. But this is, like I said, just your dermis and your epidermis. Here, you're able to peel the skin off. Pretty good, yeah. Full thickness burns, this goes all the way down to the subcutaneous. It will affect nerve endings, blood vessels, even to the point where it can affect bone. It's going to be white, waxy, charred, hard, leathery-like for the most part. Now, this is a London-Brower chart. It's a nice chart. It works a little bit more accurate to determine total body surface area burn, but it's a little bit too much for pre-hospital. We kind of, and I don't know why the bodies are not showing up on your video, but if you can kind of picture in your minds the different rules of 9 here. We go ahead with the adults, the head, the chest, the abdomen are all 9s, front and back, each 9. Each leg, front is back, or front is 9, back is 9, but we use that to go ahead and determine total body surface area. To be very honest with you, we're not very accurate. We have a tendency to forget about it, but remember, we do have it in our protocol books. Now, children are a little bit different, and infants, obviously, they use a different rule of 9s also. So we do see with some of these burns, vascular problems do occur, depending on the depth of the burn itself. When we see this happening, blood flow to a certain area is greatly diminished. And anytime we're lacking blood flow to an area, that skin becomes ischemic and ultimately will die off. And so they need to do what they can to get blood flow to the area. We start to see a fluid shift. Again, here's where we have capillary permeability. Fluid starts to shift from the capillaries to that third space. We start to see swelling occur. And this is why, too, these patients become dehydrated, because they start losing fluid here at this point. And it'll occur after the first 12 hours, up to 36 hours after the burn occurs. Now, is a burn a trauma or just a medical? Well, it depends. If I go ahead and I put my hand or put my arm in some really hot water, that's just medical. But if I'm outside stumbling around, or I throw gas on a fire and I have an explosion and I get blown back and I fall down, then we would consider it a trauma. Depending on the history behind the burn, we will transport those patients to the appropriate facility. Now, they'll generally take care of the trauma patient first, and then they'll send them off to a burn facility, depending on what might be going on. So, when we have fluid imbalances in these patients, we see the shift in fluids. We can see them start to have metabolic acidosis. High potassium levels, low sodium levels might actually occur. And they end up with dehydration. This fluid starts to stabilize itself generally after 24 hours. We see the capillary leaks stop for them. Blood volume is going to go back to increasing, and we'll see body weight usually return to normal at this point. So, different phases of burns, 24 to 48 hours. This is where we see a lot of fluid loss. They end up with edema. We have reduction in blood flow to areas and damage. The only thing we can do at this point in time is give them fluids. Now, some of you guys might remember the Parkland formula that you learned back in paramedic school. We don't really teach that anymore. Obviously, that's more of a hospital thing, but it's taking the amount of fluids and dividing it up, how much in the first 8 hours and then how much in the second 16 hours for these patients. Big thing with the burns too is also maintaining body temperature. Depending on how bad the burn actually was, were the nerve endings damaged, they can become hypothermic. When they become hypothermic, they start shivering. When they start shivering, they produce heat, and that's not what we want to actually happen. Here's a better picture of the different rules of 9 for these patients. Respiratory. A lot of people with inhalation injuries or inhalation burns, they get a little freaked out. They don't want to get aggressive with these patients. These patients need to be intubated very quickly. You need to be aggressive with them. Your patient, they're sitting there, they're talking to you, you see redness and soot around the mouth, and you think, gosh, they're fine. But their voice is a little bit hoarse. Maybe they're coughing a little bit. The last thing you want to do is go ahead and give them etomidate and Versed and put them down and intubate them. But that's really what you need to do, because you don't know how quickly that airway is going to swell. You know, my lab coordinator, Cody, works for Chicago Fire, and they had that firefighter a couple years ago that died of inhalation injuries. And Chicago doesn't have a drug-assisted intubation protocol. You know, and they always sit there and they wonder, had they been able to intubate him early, would he have survived? You know, it's a terrible position to do the what-ifs all the time. But, you know, with these patients, being aggressive, acting aggressively, managing that airway. Again, no airway, no patient. You can always go fall back on the fact that, well, if he stops breathing, I've got the quick trach, but what if the swelling is lower than that? You might not be able to adequately ventilate them. You know, so use your etomidate, your Versed. You know, explain what you're going to do to the patient. They may not like it. They may, you know, even go to the fact that they might refuse. Listen for any wheezes. Okay? If they're wheezing, that's also an indication of an impending airway obstruction. Now, the other thing they look for in these burns is there full circumferential burns? Remember, when the tissue kind of dries up, it'll start to squeeze the body, whether it's the arm, whether it's the chest, whether it's a leg. You might actually go ahead and have compartment syndrome that will develop there. But the big thing we worry about the chest. If it starts squeezing the chest, they can't adequately ventilate. Here they use escharotomies. They go ahead and they basically cut down through the skin itself to go ahead and allow for the expansion of the chest wall itself. You know, this patient obviously, his world of hurt for the most part, but you know, they're probably going to end up having to do skin grafts on this patient to go ahead and a lot of debriding. So this is this Parkland formula I was telling you about. They want to go ahead and give a certain amount of fluid. So they use the 4 milliliters times the total body surface area to times it by their weight in kilos. And they take the first half of it and give that fluid in the first 8 hours. Then the next 16 hours, they give the second half of that fluid. That's why it's really important when you guys go ahead and you administer fluids, write down in your report how much you gave. I know the nurse should be able to figure out, you hung a 1,000 cc bag, there's 700 cc's left, they should be able to figure out that you gave 300. Or, well, we're going to continue to give the rest of this 1,000, now they've got 1,000 cc's in. But just to make sure that everybody's on the same page, put how much you actually gave the patient in the field. They're also going to give enough fluids to maintain urine output. Again, it comes down to the damage that might occur to the muscles, the myoglobin within the body, which will cause the patient to go into renal failure. They actually like to have that 30 mLs per hour. And if it drops down to 5 mLs per hour, they're going to up the fluids to go ahead for these patients. Respiratory-wise, pneumonia is very common with burn injuries. Infection, you know, if the dehydration, the trauma don't kill them, the infection might. So they want to make sure that they're, you know, giving antibiotics if necessary. Topical antibiotics such as Silvadene. Tetanus shots, they'll go ahead, and plenty of fluids. If there's too much dead tissue, they'll start debridement, where they're actually going to go ahead and cut off that dead tissue, so that's necrotic. They're going to leave the blisters alone because the blisters do provide some type of protection to the open skin underneath. Okay. Yeah. Big thing when dealing with the burn patient, obviously, airways first. No airway, no patient. We've said that many times today. Making sure they're monitoring vital signs, patient's weight, making sure that they're hydrated enough, making sure that you know, they're preventing infections. If you've ever gone to the burn centers, they're very, very particular in keeping things sterile, making sure everything is, you know, they're not going to end up with some type of infection. Pain management is also very important, which we'll get into in just a second here. So, as far as our protocol is concerned, we follow our routine trauma for burns, and then may indicate presence of airway, or watch for airway compromise, hoarseness, wheezing, stridor, any carbonous sputum, singed nasal hairs. Consider advanced airway. Consider using your drug-assisted intubation to go ahead and intubate them. Then we go on to pain management. 2 milligrams, well, we use morphine. Why are we using morphine over fentanyl? Morphine lasts longer than fentanyl, okay? 2 milligrams, is that really going to do anything for the patient? If it's a severe burn, probably not. These patients are going to get a lot more than that once they're in the hospital. But you want to give it 2 milligrams, over 2 minutes, up to 10 milligrams, okay? And then we're going to go ahead and take a look at what kind of burn it is. If it's a superficial burn and it's a thermal burn, here we'll go ahead and use moistened gauze to go ahead and cover the burn. Try and cool it down a little bit. We have to be very careful if we're at 20% of the total body that we're not going to cause hypothermia. We're not going to induce shivering for these patients. We don't want to overcool them. If it's second or third degree or partial to full thickness burns, then we're going to go ahead and just cover them with a dry, sterile burn sheet. Electrical burns. Make sure we're watching for that entry wound and that exit wound. And then what pathway did it take? Remember, the electricity is going to take the path of least resistance, so it'll follow nerve endings and blood vessels. Did it go through the heart? Watch for cardiac arrhythmias. Even some patients that survive an electrical burn need to go to the hospital. They need to be in a 23-hour monitoring situation. It seems like at about hour 20, 21, 22 is when they will develop arrhythmias. So we want to watch for signs and symptoms of arrhythmias for them. Also, in electrical situations, those muscles can contract so tight that it actually can break some of the bones. So you want to make sure that you're assessing for any broken bones at that point in time also. Chemical burns, do we just go ahead and rinse those off, wash them off? Well, it depends on what it is, right? So how do you know, if you see this dry powder over them, how are you going to know when you get out there what you're supposed to do with that chemical?
Hazmat team.
Yeah, you got a hazmat team. You got the hazmat books you can use. You got poison control. You have all these references available to you. A lot of them simply brush them off. They may interact with water, so you don't want to go ahead and introduce water. You might want to go ahead and brush them off and then rinse them off, which is the pen. Remove the clothing before you go showering anybody. Okay, set up your decon shelters. If you have eye involvement, maybe you've got to flush somebody's eye or both eyes. If they have an eye washing station right there, works really good, use theirs. Otherwise, you can go ahead and take a nasal cannula, cut the prongs, put it over the bridge of the nose, hook it up to a bag of saline, and then kind of turn the head so that it flushes out that eye, and that'll work as you're on your way to the hospital, okay? We want to make sure that we're not contaminating the uninjured eye if we have just one eye that's been injured, okay? Pediatric burns, no change here compared to the adult protocol. The only difference is we're looking at the dose of morphine. 0.1 milligrams per kilo is our morphine dose to a max of 10. Now, you guys are out there, you've given your max of your 10 morphine, and you still got a couple minutes of transport time. Could you call medical control and say, hey, listen, I gave this guy 10, he's still in a lot of pain. Can I go ahead and give him up to 200 mics of fentanyl? Go big, ask for the full amount. Tell them you're going to monitor the respiratory. But ask for everything you can get right off the bat, because this patient is going to be in a lot of pain. All right. Just got a lot of statistics here. I'm going to go to the ones that I think that matter here. Okay. Almost done. A couple more slides. So, this chart shows medication that was given by EMS providers based off of system. And we are actually trauma 1A here. And what it talks, I know it's kind of hard, but we had 8% of all of our patients that required medication, we gave fentanyl, 1.8 morphine, 1.8 refused pain management, but 88% of all of our patients that could have been given pain management were not given pain management. That's a great deal of medication or patients that could have been made better by you guys, not just your department, but by EMS providers in our system if they would have chose to give the medication. One thing you guys got to remember, I know that you say, oh, I'm 5 minutes from the hospital, but first of all, giving them pain management before you move them. It's kind of nice. You think about it, if that's your kid or your mom with a broken hip, you're going to want those EMS providers to do everything that they can to make that your mom or your child comfortable. Plus, once you get them to the hospital, even though you've been on scene with them for 10 minutes, get them to the hospital, even if the stars are all aligned, that everybody is standing there waiting to treat just that patient, it can sometimes be a half hour before they're going to get pain management. We're busy, Evanston's busy, it can be even longer. So the sooner you can get that patient feeling better by giving them some pain management, the much better you're doing for patient care. This one here, how many times, once we gave the pain medicine, did we reassess? Now, did the pain management help? 36% of all patients we gave pain management to, we did not reassess. 2.7 patients said their pain got worse. 14% said the pain stayed the same. And 46% of the patients that we gave pain management to said they did better. Okay? Changes in pain without medication, 79.6% wasn't recorded. They didn't record if the pain got worse. Let's see here, 17.1 said it stayed the same. 2.8 said that without the pain medicine it decreased. And 0.5 said it got worse. Worse. But again, not a lot of times are we recording this. If your patient is in pain, we need to record pain management. Now, I know it's really difficult because sometimes you get the patient that says, oh yeah, I'm going to pain at 10, and they won't get off the phone, and they're laughing and they're joking and everything like that. And you think, I am not giving this idiot, fentanyl. They don't need it. You got some patients who say, oh, my pain's at 2, and you can see from the glistening sweat, the clenched jaw and the clenched fist, that they're in more pain than what they're saying. But there's more to just assessing a number, 1 to 10. That's pretty worthless by itself. What's their vital signs? Is their heart rate up? Is their respiratory rate up? Is their blood pressure up? What does their face look like? Are they laughing and joking but say they have a pain of 10? Probably not so much. Document. Patient states pain is 10 out of 10. However, vital signs do not increase or indicate increase in pain level. Tells me right there that you chose not to give pain management to this patient because they were full of it. If I was reading that report. I would put that one aside and wouldn't even use that one as a QA for this QA program. But using pain management, it's, we're trying to do what's best for our patients overall. So what was our studies overall? 37% of patients had no initial numeric evaluation. Like I said, that numeric evaluation is only good if you pair it up with the facial and the vital signs itself. 5.6% of patients reported a pain level of 0 to 4, 42, 5 to 10. 11 were recorded without a pain number and they received pain management. 63 or 69.3 had no reassessment. So if you give someone pain management, a few minutes later, did it help? And then document it. We want to know, are you doing the interventions that you're doing in the field, are they worth it? Are they helping your patients? We're really hitting up the evidence-based medicine, okay? So here's our pain management protocol. We give 1 mic per kilo for adults. For children, it's 0.5 mics per kilo. And we give to a maximum of 200 mics. Same thing, adult, 200 mics. If we give too much, we've got Narcan. Now, one thing to consider, if you are giving any type of narcotic, give the patient some Zofran before you go ahead and administer. It wasn't put in the protocol, but we do know that when you guys slam in morphine or you push it too fast, it can cause the patient to go ahead and get a little sick to their stomach. Because remember, morphine releases histamines, specifically H2 histamine, which causes increase in gastric mobility. And so that's why a lot of times they get sick to their stomach or vomit, because you've actually created that problem. But you can alleviate that. It's no big deal to go ahead and give them the ODT, or give them, if you're giving it IV, to go ahead and push some Zofran beforehand. Then you don't have the likelihood of them possibly vomiting in the back of your ambulance. All right, anybody have any questions on anything we've gone through today? All right.
Yeah, no problem.
There's one other little thing I'm going to quick talk to you about. I know. They just did a statewide drill the other day regarding the stockpile for medications in the event of an outbreak of something. It doesn't matter what, an outbreak of something. And I'm not going to go through all of this with the history but you guys do have to be aware, because you've got the public health department here in your own community, okay? So what this is you guys are the ones that are going to end up vaccinating your general public. Yeah, I know you're all thrilled. But there is a benefit to you guys being the ones to go ahead and vaccinate your citizens of Evanston and part of Cook County here, is that you guys will get first dibs on the medications for you and your family members. That's, and I guess you think about it, that's pretty big. But so our stockpile is basically a 12-hour push package or a chem pack, or the chem packs. I think those, I can't remember where he said those are seen, but it's going to be, if we need to give antibiotics, if we have chemical agent antidotes, vaccinations, or any other emergency medications are needed, IV supplies, airway management, you guys are the ones that are going to be working these pods, okay? You're going to be the ones that are, you won't be doing the health screenings. Doctors and nurses will be doing those, but they'll be sent to you for either you guys giving them the medications or administering the vaccinations. So, let's see here. So the chem packs itself, these are for nerve agent antidotes. And I can't remember where Adam said they're keeping that. Oh, I know they're at the hospitals. I'm sorry, they're all at the hospitals. But what's going to happen with the deploy? Locally, it's going to identify the need for the situation. We're going to have a declare of a disaster. Now, some of you guys might remember when we had the H1N1, technically you guys are not qualified to go ahead and give vaccinations. But when the H1N1 came about, the governor signed the Emergency Act to say you guys can now give vaccinations. The protocols have changed a little bit through the state. We are actually, as part of Mobile Integrated Health, allowing paramedics now to vaccinate. So they're kind of going underneath that guideline at that point in time. So, but once the disaster has been declared, you guys will be deployed to your local health, to the pod itself. And this is going to be the area where they're going to go ahead and make the determination who is a candidate for these medications and who is not. Basically, anybody that shows up that's well, they're going to send away. They don't want these people there. They only want the sick people. And you're sitting there thinking, well, I don't want to be around any of these sick people, and they've got whatever vaccination or disease. That's the last thing you want to be around. But remember, you guys will receive the first dosages, and you will receive dosages to take home and give to your family members. Okay. So, what are we looking at? Well, if there's any confirmed cases, if there's a disaster declared, if the director itself has requested any external supplies, IDPH will augment all emergency services, and dispensing of medication is going to be the cornerstone of mass prophylactic operation at that point. This is going to be mandated by you, or mandated to you guys. You really are not going to have a choice for the most.
Are they going to explain this medication they're giving us, the research or whatever, or are they just going to give us medication?
They're going to give it to you basically and say, here, go ahead and vaccinate these people.
Why not?
Yeah. I'm being brutally honest. I mean, I would love to say, yeah, they're going to sit you down in a classroom and say, here's the indications, contraindications, and everything else, and everything you need to know about it, but let's be real. It's not going to happen. They're going to say, here's 150 vaccinations. Go start over there at that line. And that's really what's going to come down to it. But because you guys are so fortunate to have the public health in your community, you guys will be the first ones to be deployed, okay? So, you're not quite alone. Skokie's got theirs too, and that's why this one's been for Skokie. But so, who's going to be allowed for medications for mass distribution? Well, all village employees, first of all, will go ahead, or city employees will be vaccinated. Then all volunteers, and you can take Evanston and put that where Skokie is. All residents. So this is the order that people will be vaccinated in. Spontaneous volunteers, temporary residents, hotels, workers, etc. Special population. Then they'll go ahead and do the homeless, the disabled, group homes, and anybody else after that. So that's kind of the order that people will be vaccinated in. If it comes down to it, you guys obviously will be informed where you need to report to pick up your medications to take home to your family. You will have to report that I need, I've got 5 kids and my wife. And they talk about people that live in your home, okay? Those are going to be the first ones that are going to get it. And then once you go ahead, critical personnel account for over 37 prophylactic dosages in the village alone of Skokie. I don't have any numbers for Evanston. But the household members will be advised whether or where to report. So if you guys can't get to home to give the vaccinations to your family members, your family will be told, go here, and then you will be first in line to get your vaccinations. So, yeah, this is just the whole chart. Now, they're going to give you, let me go through so these forms are what are going to be given to you guys to fill out for on each patient. Information for household, the names, the medications, the numbers you'll write on there, and then turn this back in. But this is actually going to be for each person or for everybody in your household. This will be the algorithm, and this one is for anthrax, the plague, and you kind of start here. But again, this is what triage is going to do or screening is going to do before they even get to you. So you don't have to worry about that. And this is one for the distribution of Cipro. But they will get, this is what they'll basically hand to you, okay, and say go. Okay. And yeah, these are just the data collection forms. And that's the pharmacy people. So I just wanted you guys to know, since this last week we did have a statewide disaster drill that started, I think it ends today. We had a mass distribution site at St. Francis, because obviously all hospital employees will get dosages for their families also. The health department will give you your dosages, so you won't have to come to the hospital to get them. They'll bring them to you here. But it's just, like I said, you're going to be responsible, so it gets to be a little overwhelming. All right, here's the quiz.